What's up, everyone? Welcome back to Optimize Health. I'm apparently your co-host, Josh Porter, along with the host, Mandy Livingston, or at least that's what I've been told here lately.
I love that you know your place in all this.
I'm just giving you one chance there, okay? You'll never hear that again, I can tell you that.
We're only going to say that one.
Yeah. I'm just going to start saying the founder of Optimize Health and then the host. How about that?
Good Lord.
I'll just blow it up a little bit. What's up, girl?
Listen, I'm just over here living the dream. This has been, I don't know about you. I've seen you about 3 times today, I feel like, but in different capacities. But I'm like, it's only, I don't even know what o'clock in the day. And I feel like I'm losing my mind. Like I've done a week's worth of stuff in one day. Do you feel like that today?
I feel like that every day. Yeah. It's the joy of life, right?
That's fair enough.
So we don't have a guest today, which is always
you and I.
Yeah, always kind of fun because it just means that we get to talk about some random stuff. We're going to talk about the musculoskeletal syndrome of menopause. We'll talk about some peptides. We'll talk about whatever you want to talk about.
I'm not a fan of menopause right now, just so you're well aware. Like,
maybe you should lead this discussion then.
I'm not a
fan. The personal testimony of Mandy Livingston.
I'm not a fan. I like to call it, this is what I've started with, like my people. My not so friendly friend Perry, first name Perry, last name Menopause.
Ooh, I like it.
He's my not so friendly friend, and he's a he.
Yeah,
he's
for
definitely
sure.
a he.
Yeah. Well, your husband had a surgery.
He did
last week, and he felt like he understood what it was like to have a baby, at least, right?
AKA poop.
Yeah.
I was like, Josh, God love him. He's never had a surgery before. So I've been kind of babying because I didn't know what I was going to get in this. When he's sick, he likes to be left alone. He just goes in a dark room and you just check to make sure he's still breathing.
Yeah.
And that's all you do. Oh, no. That's not what we do with surgery.
He needed you.
He needed me. I was helping him up. For those of you who know him, he's like 6'2". I'm not. I'm 5'4".
Yeah.
So I'm like trying to get his big old butt off the couch and stuff. But, you know, he is taking care of me during surgery, so it's my turn. But he had a umbilical hernia. Almost said hemorrhoid. Hernia. That's not the right area.
Yeah. It's a good thing you got me here to correct you on the medical terminology.
but he had that. So, and they had to actually cut him open. It wasn't laparoscopic. It was, they had to cut him open and all this stuff. And God love him. And so he's got a surgical site that I swear is as big as the end of my pinky.
I don't see how he's going to make it.
You would think that it was the size hip to hip.
Yeah.
Bless him.
It's essentially a C-section for men. At least in his perspective, from his perspective, that's what he's enduring right now.
Oh,
yeah, Rob, I feel sorry for you, brother.
He is.
Yeah.
He is.
Yeah.
So it is quite the adventure in the Livingston household right now.
Oh my gosh!
But he loves to discuss and be very proud of the fact that he poops, and if something goes in, something comes out. Something goes in, something comes out. Well, all that did not happen as of Friday and into Saturday. So we thought our world was coming to a direct stop.
Yeah, his mental capacity was at the limit right there.
He was like, "This is it."
Yeah, take me to the ER.
I'm going like this is it. So when it finally did, move around into normalcy, he was like, he came downstairs and he was like, "Babe, I'm pretty sure that's what giving birth is like."
Yeah.
And I looked at him like he had 4 heads, and I said, "Listen, I'm gonna let you get away with a lot in this last couple of days, but that one, that's a no-go.
Take it back.
Yeah, take that.
You should have given him some mag citrate and been like, "Hey, just drink this and it'll be fine." Oh, well,
I did.
Now I know. See, you got him. Yeah,
I did.
Yeah, okay.
He
That's
had
hilarious.
magnesium glycinate and he had citrate, and then he was also taking Miralax, which the doctor was giving him.
Yeah.
So, but the citrate, he only had like a little bit.
Cupful.
Yes. And so he was like, "What's it going to do?" And I was like, "Well, I don't know. We'll see." I don't think it did anything, if you want me to be real honest with you. But nonetheless, we were trying to work it out.
So you can add nursing to your credentials now, since you're having to, just be a caregiver and man.
Apparently. But with all that being said, in the midst of all of that, I'm at an age where the menopause thing is a thing.
Mm-hmm.
I know you're living it with me because I will flip turned upside down on you too.
I see it every now and then. Yeah, let's just say it that way. Yeah, I feel like it's all around me. It's funny that you say that because I was literally having a conversation with somebody today who's asking me to come and speak. And I said, well, listen, I'm a dude. You're asking to talk about menopause. I know that can be a little different. And she's like, you know what? I think it's so important for men to be advocates for women in the season because of things like divorce and workplace issues. And she's like, so we love the fact that you. And then they were like, and we like your Southern accent. And I was like, so wait a minute. Why do you really want me?
Am I adorable? Or do you want to hear what I have to say?
You're filming in the South and you think my accent's funny, but nonetheless, I'm like, all right, whatever. So, but yeah,
God.
I'm surrounded by menopause.
You don't know what's coming day to day. Like, truly, you do not know what's coming day to day.
Yeah.
You think you've got it licked and you're like, okay, I'm cruising. This feels great. And then, like, you're dizzy or your heart's racing or your shoulder freaking hurts or your knees are going out or the only thing I have not suffered from, and I'm going to say it and it happens tonight and I'm never speaking of it again, is hot flashes. I've not had that, which I know is a typical.
Yeah, one of the most common symptoms.
Yes, and for whatever reason, that one is just kind of not laying into me yet. I say that and I may show up with it in the next 5 minutes. Who freaking knows?
Yeah.
But I'm telling it's making me crazy.
Yeah.
It's making me crazy. It's because it's the when you think, okay, I'm past that, or this is okay today, or what, and then that curveball comes through. Like, why am I dizzy today? Why?
One of the things that so technically you're in perimenopause, right? Late stage perimenopause, based off your most recent labs.
Not being my age,
and
that was
which is actually the hardest. Because it's, kind of the season of chaos. And so I always tell people, if you were to give an analogy of like perimenopause versus menopause with an EKG, menopause is the equivalent to an EKG being a flat line, right? You're dead. The ovaries are dead. The equivalent to EKG with perimenopause is like AFib, right? We with atrial fibrillation, it's this little catchphrase or mnemonic is irregularly irregular. So there is no pattern, right? And I'm like, I don't know that there's a better picture of what perimenopause looks like for women other than you're irregularly irregular.
Yeah.
One day it's going to say one thing, and the next day it's not going to communicate nearly as well, right? In that system, and so the phase you're in is the hardest phase, for sure, because your body's trying to do some things, but then not enough, and you can have a good day followed by 3 bad days. You can have a good 2 months followed by a terrible 3 months. You know what I mean? So it's just a tough season to try to figure out how to support that.
Well, I told my trainer last week, I was like, I'm having a good week.
Yeah.
Just like, I'm having a good week. I'm lifting really well. Like, I'm recovering really well. I'm sleeping really well. And I'm like, I kind of don't want to let it out into the atmosphere so that something weird just decides to sneak up and smack me in the face.
Yeah.
Hello, this week.
Yeah.
Where I'm dizzy and my heart's racing and I'll be driving down the road. I was coming here, driving down the road, and all of a sudden I'm like anxious. Just no reason. Like, I'm not angry at the person who's riding in front of me,
right,
slamming on the brakes. Like, I'm not doing any of that. Just random out of the blue, there it comes. And then there's just those strange, crazy, the mood swing things where I'll be perfectly fine, everything's happy. And then I'm like, I'm going to punch you in the face because you can't get off the couch by yourself because you just had surgery. And then I'm like, oh my God, that's awful.
Yeah. Yeah. Just all over the place.
It is
it's
insane.
Like an
it is insane. And when your own voice in your own head is going, girl, calm down. But your external voice is going, no. You feel like you're a lunatic. Like, all right, just load me up, straight jacket, throw me in, give me a hot minute to calm myself down.
Well, just think about what it would be if you didn't work in this industry. You really would think you're crazy.
Seriously.
I mean, I think that's one of the things that we focus on is helping women who have your symptoms understand, like, you're not crazy. This is a physiological change, right?
Yeah.
The neuroendocrine system, the way your brain is communicating with the rest of your body is vastly different as you're losing certain hormones. And so it makes you kind of feel for those women who literally don't know where to go, and you do.
Have you seen that We Don't Care Club thing?
Yes.
We do not care. Okay. Here's my philosophy on that. I wonder two things. I wonder, one, is it really about being in perimenopause and menopause? Or two, is it the stage in life that I'm in where I've had so much maturing, like so many life things have happened that I have realized that's not important to care about?
I think it's both, probably.
You think so?
Yeah.
I think some of it is attitude.
Well, I think I think the design, right?
Yeah.
I mean, I think you have to really kind of understand that there is a purpose of hormones from the standpoint of the physiological component for, procreation and things of that nature. And as you morph into kind of the grandmother stage, right? You like physiologically, you're also going to not really need to have all those motherly instincts and patterns and thoughts. And so there is a physiological response. But I also do think that there's an element of you've lived long enough to where you also are on the other side of it. And you're like, listen, I don't have 80 years left, right?
Yeah.
I'm at this point where I don't give two flips what somebody else thinks of me.
Yeah.
Because your time matters, right?
Yeah.
That quality probably does play a role in all of our minds of like, 30 more years, like I want to make the best of this.
Yeah.
And I'm not going to let somebody else dictate how I think or feel about something.
I think we've also kind of flipped in, like, my husband and I, like, he, for the longest, didn't care about it. Like, nothing bothered him, but he just cruised on, like, oh, the kids are blah, 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 blah. And he's like, it'll be all right, But now he's Mr. Wilson. Now all these things get on his nerves, and I'm like, why does that bother you? It's almost like we changed roles to some degree. Where did we miss each other being in the middle, though? Where did we both not, are on the same page to where, like, the things that don't bother you, you're both just cruising on the same level. I feel like we've missed that part. Like we slid right past each other on that.
Yeah, that's a deep thought. I'm like, I don't know. I'm trying to think with my relationship with my wife. I think she'd probably say the same thing of, that there's not really as much of a balance there. It's like you're on one extreme, the other. One of the things that I've been on a journey here lately, you'd be so proud of me, Mandy, is practicing a little bit of self-care.
I am proud of you for that.
So maybe this is good to talk about because, I think it's important for people to have the transparency of like what we're talking about with you, right?
I'm a hot mess.
Yeah. You've been pretty transparent about that for a long time. But so work-life balance, families, financial strains, business ownership, patient care. I mean, everybody's got those stories, right? Whatever your work is. I mean, it's not like my job's more important than anybody else's. But those stresses and strains they play a toll on you. They take a toll. And, probably about 3 months ago, I really was coming to this point where I'm interacting with 80 to 100 patients a week, helping them become the best version of themselves. And I'm starting to struggle with like, I don't know that I'm the best version of myself because I'm not practicing what I'm telling everybody else. And so it's taken me a little bit of time to morph that with some, time off and things like that. But physically, I've started with a trainer because I felt like I was going into the gym and in between sets, I would send emails and text messages.
You had no accountability not to do that or whatever you want to say.
Yeah, it was just too easy to not be focused, right? And so a couple weeks ago, I started with a trainer. It's going incredibly well. I actually texted him this weekend. He had me do this side plank, an oblique side plank. I'd never done it before. And I did it on Thursday, and I wake up on Friday, and I go to tuck my shirt in, and I'm like, my love handle hurts. I was like, what did you do to me? And so I'm like, bro, my love handle is like tender to the touch. And he responds, love that. Yeah.
Mission accomplished.
Yeah. I was like, oh my gosh, I didn't even know I had a muscle back there. Like this hurts. So I've taken that step. I did an extensive lab panel, which was really pleased to see that a lot of it was really good. My cardiac panel, so looking at my lipid profiles, looking at my inflammatory markers was all really, really good. I've got a few tweaks here and there, but it really was like, man, not as bad as I thought it was. I've signed up for a coronary calcium score, which is a test a CT scan that we can do, and we have a lot of our patients do it, where it looks at how much plaque buildup do you have in your carotid arteries. Really important for guys, especially as we get closer to that 50 years old. And again, my wife's like, listen, I'm not ready to lose you to a heart attack. And one of the things I tell my patients all the time is you've got 3 ways to know you had a heart attack, right? A heart cath, you don't really want that. A heart attack, or you do a coronary calcium score,
you
right?
die.
Or you die. There's a fourth. So looking at it from just that preventative measure. So I've done that. I did a VO2 max today.
Yes, I heard.
Girl.
I could. That was not for me.
It should be.
The thing freaks me out. I can't snorkel or scuba dive or any of that stuff. Bless you. I can't do any of that because I can't have that on my face.
Yeah. It's totally fine until it's not. About the last 45 seconds here, let me walk somebody through it. So the purpose of a VO2 max is to look at really kind of your maximum output. How hard can I go? And then from there, you can look at how well do you breathe through that. So what's your oxygen consumption? What's your carbon dioxide exhalation? And so the ability to exhale that carbon dioxide, so you're breathing out enough, so you're not building that up. So it measures those things. It also looks at metabolic rate, so it can help you determine what zone, for example, what zone of exercise is really the best for you as an individual to burn fat. So it can help you to see like, hey, you really don't need to be in zone 3 a whole lot, or you need to be in zone 2 more, or whatever. So it gives you a lot of these parameters. So from what we would call a cardiorespiratory fitness test, it's really kind of the gold standard. So they have a rest test. So I did mine at Summit Physical Therapy. Kevin Koska is the owner. And so they have a rest test, which was awesome.
Is it literally sitting like in a recliner rest?
Oh, yeah. I'm leaned back. My eyes are closed. They don't want you talking. So literally you're just, for 10 minutes, you just kind of sit there and meditate. They don't even want you on your phone because anything that elevates your heart rate. So they don't want you to scroll. So, it was like, man, this is pretty pleasant. And then, and the mask is on, but it's not unbearable. It's super comfortable. Well, then you go to the bike, and their wellness coordinator was awesome. Hope is fantastic, but she kind of walked me through it. And I think in your head, even I did a VO2 max when I was in college, but in my head, I knew like there's a warm up and there's the push, right, where you go max. And then I thought like, I'll be done. So so they do it on a bike, and the first 3 minutes you have to get to 100 watts of power. Again, as she's telling you that, you're thinking, well, it's no big deal. It's pretty hard. I thought this is not a warm up. About a minute into it, I'm like, no, I'm pretty sure my heart rate's elevated and I'm sweating pretty good. And then she's like, so you do the 3 minute warm up, and then you go into kind of the max effort. So then you start pushing your wattage up 15 watts, right? So 100 to 115 if you can, and you have to keep it there for a minute. I did not last very long before I was like, I'm pretty much there. And she's following it, so she kind of knows like, hey, you're probably getting to that point of exhaustion because
she's not gonna let you fall out.
No. So she's like, all right, let's finish it up like this, finish this last minute. Well, then I'm thinking, sweet, it's called active recovery. I'll just scroll on through this thing, Well, no, she's like, all right, we're going to bring it down for like 2 minutes, 2.5 minutes. I don't remember now. I lost all the oxygen in my brain by this point. And so she's like, we're going to keep you to go back to the 100. And I'm like, I'm sorry, what? I'm thinking like, girl, I just gave you my max effort, and now you're telling me I've got to do this for another 2.5 minutes of like where I started.
Longest 2.5 minutes of your life.
Oh my gosh. I mean, and I'm not saying like, I literally thought when she said 45 seconds, like I can't do it, And so I had to like get creative in my head, and I'm like, I can do this. But I'm telling you, I mean, when I got off, it was mostly my legs. I mean, my breathing was pretty heavy, but mostly my legs. I literally felt like I had just squatted 800 pounds 15 times. I mean, my legs were so dead.
Oh my
and I had literally rode the bike for 6 minutes. I mean, it was not like.
It's not like you've been there for 30.
Yeah. And then we did an interview with him, and I couldn't catch my breath. I was like, I promise you guys, I'm not nervous. I just can't breathe because I just did this VO2 max. But it's a great marker for cardiorespiratory fitness for somebody who's looking for longevity. And so I go back. I haven't got my results back, but I go back for an analysis, and then we'll kind of go from there. So I've been, dialing my sleep. I've had
You said this has been good, though.
I had 100% sleep score the other day.
I know you told me. I'm jealous. I've never had 100.
And I've never really been a big drinker, but I'd have two glasses of wine or something like that most evenings. And I backed off that, and I'll have an occasional drink now on the weekends or something. But like my sleep was drastically improved. So that has, even to the point where most days now I have 1 cup of coffee and I'm pretty good. But yeah, I know. Like energy drinks, nothing. Today, don't ask me because I went to Vegas this weekend. So
this is my shocked face.
Yeah, I'm not kidding.
I know what you drink in the day, caffeine.
Even yesterday. Now it was a lot of travel, so I was trying to get back on the 3-hour time difference. But I had 1 cup of coffee yesterday and was fine. So
wow, that's good.
It's just looking at little things like that to where it's like it makes such a huge difference, So yeah, I'm on a health journey.
I'm proud of you.
Yeah.
I'm proud. You're on your health journey.
That's
You're
right.
not out there. This is the part that I'm proud of you for. You always spend your time trying to find ways to help your patients improve for certain things, and you put yourself on the back burner, even though you hear chatter in your ear.
I do.
But this is the first time you've kind of put yourself in the forefront and said, okay, listen, I'm going to lead by example.
Yep.
And I'm a true believer in practice what you preach, walk your walk, if you're talking the talk, like those kinds of things. In the space that we're in, we have to be that.
Yeah.
Like we have to be that. You do not want to go to a hairdresser whose hair looks like crap.
Right.
At the end of the day.
I went to a dentist today and I was like, you look a little young. I'm not having you do my crown. Just saying.
You just got your teeth last month.
I hope you're not listening to my podcast.
You're so mean.
But I'm going to somebody else. But you're so right. It's like.
It's true.
Yeah. I remember when I was in, kind of the mainstream medical model, and you would consult a dietitian, and a dietitian would walk in and they're like 60, 70 pounds overweight. And I'm like,
what you talking about?
I'm not saying they don't know what they're talking about, but like that rubs people the wrong way.
They know what is in a book.
Yes.
They do not know what is a day-to-day, real-life example.
Right.
Because the book, great. That's a fantastic outline. But sometimes, our friend Perry, doesn't want to play by the book's rules.
Right.
Don't want to play by the book's rules. You do all the things the book tells you to do, and Perry goes, hold my beer.
Oh, wait a second.
Here's some belly fat for you.
Yeah.
See what you can do with that. Just stupid crap.
Yeah.
Stupid.
I will say, speaking of the belly fat, because I had a patient reach out to me today, and we did a continuous glucose monitor on her. Her hormones are in really good shape. She's still kind of struggling with being able to lose some of that weight, and it's not an insulin issue. We've checked her fasting insulin. Everything that I've looked at has looked pretty stellar. So I actually recommended she do the VO2 max. I just said, hey, this may put us in a place where we can understand a little bit more nutritionally. So I'm really excited about the fact that we actually have that here in Chattanooga to be able to offer that to patients, because I think it's going to take people to the next level.
Well, okay, so staying on that same subject, and we were talking about peptides. So I like peptides.
Yeah, me too.
A variety of them. Not just, I'm not just like a one and done kind of girl. I like.
You're a dabbler.
Yes, I'm a dabbler in the peptides. Part of that is one of our practitioners, Justin.
Yes.
He's like, oh, listen to this. We have side Instagram reels that go back and forth between me and Justin, and a lot of them have to do with peptides and jujitsu. I don't do jujitsu. He does.
Yeah.
But whatever. So with all that being said, there are some peptides that are available as well that can help me and people like me that are having those kinds of, because this is a new thing. You and I haven't even talked about this. The weight kind of staying.
The distribution.
And you know how I am about my workouts and my food.
Right.
And I'm like, I seriously want to start throwing punches and laying hands because I'm like, are you kidding me?
Yeah.
Like, are you kidding me? So here I am with my issues.
So, as far as peptides around weight loss,
well, either weight loss, even like mental clarity. Mm-hmm. And because that foggy brain thing happens, because, I'll call you and I'll be like, whatever that word is.
Yeah.
Good thing for you. You and I have had a relationship for a while. You understand the word poo is universal. It means all kinds of things.
Yeah.
But, just stuff like that where it's just there are certain things that could potentially help in those areas around peptides.
So, one of the disclaimer around peptides is that there's several of them that are not FDA approved, right? Mm-hmm. There's some that are, there's some that aren't. So when we talk about peptides, you just kind of got to know we don't always have the ability to resource most of the ones that we're talking about, but there are a few that we do. But in general, I'm a huge fan of what's called GHRPs, which are growth hormone releasing peptides. Probably my favorite one is one that's not FDA approved, which is called ipamorelin. Mm-hmm. They usually combine that with CJC 1295, which gives it a little bit more stability.
Is CJC available?
It's not FDA approved.
Okay.
I think the last time I looked this up, ipamorelin.
I thought it was on the block to be approved.
Well,
or I could be wrong.
Yeah, I think it's in a phase 1 clinical trial. But all of these work similarly. Some work on the pituitary, some work on ghrelin, which is a hunger satiety hormone. But essentially, ipamorelin, in my opinion, is probably one of the, like what I always tell people is like it's your best bang for your buck, right? Tesamorelin is great, but tesamorelin is pretty expensive. Mm-hmm. Tesamorelin, though, is FDA approved, and so people use that. Somorelin is a good one. It's very safe. It's been out since the 80s. It's also FDA approved, but it's a little bit like if you're kind of tiering these, I would say Somorelin is probably the weaker of the peptides with growth hormone. You've got albuterol, which is also in a clinical trial. That one is a lot of people know it as MK677, which is that really does attract ghrelin, so it really stimulates hunger. So it's probably one that puts more lean mass on you, and it's oral, so a lot of people like that because most peptides are going to be injectable.
Yes.
And you got to do them daily or twice daily. So those are always good. I'm a big fan of AOD 9604, which is anti-obesity drug. And essentially AOD is a fragment of the actual growth hormone strand of that structure. And so they basically were able to pharmacologically take that portion that really isolates fat loss and put it in a medication or a peptide called AOD. So there's good ones. Inflammation, I think, is broad. Mm-hmm. Even from a standpoint of, I'll go like sideways here for a second. This is not a peptide. It's called naltrexone. And I literally just put a patient on it. She's been my patient for years. She had eczema, she had brain fog, and weight gain. And LDN or naltrexone is actually combined in another medication with Wellbutrin that is FDA approved for weight loss. So we knew that it had components for weight loss. She literally texted me on Sunday and said, "Josh, the eczema's gone." She had it on her eyes. I mean, like it was all over her.
That's bad too. God love her.
Was trying to figure out any other way besides immunomodulators and corticosteroids to get control of it. So she's like, it's completely gone. My brain fog is gone, and I've lost 4 pounds. Pretty crazy. So my point in saying that is...
You hit a home run on that one.
I did. You don't hit a home run on all of them.
Right.
But looking for ways to kind of get rid of inflammation. LDN therapies are great, and that is... naltrexone's FDA approved, so that's a great resource, and it's not injectable, so a lot of people like that. But, when you're targeting inflammation, you've got probably the most popular peptide out there is BPC 157. TB 500 is often used in combination with that one. It's fantastic for inflammation in general. Mm-hmm. It can be used orally for supplement use. It can be used injectable for soft tissue, joints. I mean, it really has a great deal of benefits. And because it's getting rid of inflammation, a lot of times it has brain clarity and things like that, where you just are bringing down that systemic inflammation. So you can get a lot of different benefits. GHK, which is GHK copper, that one's, now you start to see peptides that are, I think they'll call them like the glow blends. And usually those are combinations. So they may have a little bit of the growth hormone peptides and then a little bit of GHK in it. And so the idea behind that one is you're leaning out with the GHRPs, but then you're promoting skin health with the GK copper. And as a result of that, it helps you to like look more toned. So the skin looks tighter. So there's some pretty cool. MOTS-C's another one. Peptides are so interesting to me. I think what's hard to know is where they're going to go.
Yeah.
We just, I want to be very optimistic, but at the same time, I mean, something that came on my desk 3 weeks ago was that the FDA is considering removing desiccated thyroid from the market, which is one of those things where I'm like, wait a minute, how can we in the same breath have a conversation about regulating peptides in the current, HHS department, and yet in the same breath over here in the FDA, we're talking about restricting a medication that's been out for a long time. It's like these two things do not match in my head. So it causes me as a clinician to kind of have a little bit of pause and think, we'll see how quickly peptides really do become available.
I'm hoping sooner rather than later. I mean, I'm a fan. I've used a few different peptides and for a few different things, even prior to being in this stage of life. And I can see a difference. I think part of that too is one of those things where you have to be in tune with your body. I've always said that my body's always been talking to me. I just didn't speak its language. And so until I learned what it was trying to tell me and understood how to speak its language, I was like, that's what that means. Things like that. And I think it's very important that if you're not in tune with your body, get there.
Yeah.
Like figure that out. For me, how I got there was my trainer helped me pull my diet way back.
Yeah.
To where literally I had for 3 months, I had 5 different things I could eat for 3 months to see. Then once we started adding things back in, how my body reacted to those. That was a game changer for me. I was preparing to get on stage as, for a bodybuilding competition. And so that was the goal of that. But I almost wish I had done that a long time ago because it was one of those things where I was like, oh my gosh, like I thought this was what was causing bloat or this was what was causing. I had back pain all the time and I thought it was because I was exercising. No, precious miracle. It's because all you did was drink Dr. Pepper.
Yeah.
And guess what? It caused my kidneys to freak out and it was hurting me. It was hurting my back. And I didn't realize it till I stripped it out, put it back, and immediately came back.
So do you still drink Dr. Pepper?
And what's bad is that was kind of everybody has like a stressor thing. And Dr. Pepper on pellet ice was like my thing. If I was having a day, here's where my husband is gorgeous. If I was having a day, he would come home and here he'd come with a cup of Dr. Pepper, fountain Dr. Pepper on pellet ice. And he'd be like, you okay? And like set it down in front of me. And I'm like, I am now. I'm good.
That's hilarious.
But that was like my thing. If I was stressed out for whatever reason, that was kind of my whoopee.
Huh.
And so, that's gone. Tastes like chemicals now.
Swig is
chemical, but whatever.
There's the Swig, the drink place.
Yes.
They've kind of gotten popular with their Dr. Pepper with coconut cream or something like that. It's like their most popular one. But
yeah, I mean, it was my thing for a long time.
That's crazy.
I know, but I wish I had done that before. That was just how I got in tune with what was talking to me because I was like, holy crap, like that's not good.
Yeah.
So things like that. One of the big things that's popular on social media right now for women in perimenopause is NAD.
Yeah.
Why?
Well, so NAD is a coenzyme that our body makes, and it's interesting in that roughly by age 25 to 30, 50% of NAD production is gone. That's male and female.
25 to 30. That seems very young. Like you only had it for 5 minutes.
And NAD is very important in the chemical structure with cellular health for mitochondrial production, which is like your energy source. So it's utilized with like ATP and things of that nature, which basically gives your body, your cells, the capacity to produce these cellular components that then source and help your body make new cells, right? Okay. So then you become less efficient. So we call it senescent cells. So senescent cells are kind of just low-hanging fruit. They're not really doing anything. They're really hard to get rid of. And as a result, then senescent cells have a little bit more of a propensity to damage or to, causing responding poorly to infections or inflammation or cancers and things of that nature. So NAD is incredibly important. I used it last week on somebody who's got mast cell activation syndrome, which is basically she overreacts with histamine. So she gets so if she's allergic to food or something like that, she gets in this kind of fight or flight within her histamine response, and they get super inflamed.
Interesting.
And so I'll use NAD and glutathione oftentimes in those patients to just kind of bring down the inflammation. And again, it generally works. You can also use LDN therapy for that. NAD also, a lot of people feel like it gives them tons of brain and, clarity and focus. I've had a couple patients, this would be more testimonial, but I've had a couple patients kind of unprovoked. I did not put them on NAD for this purpose, but they both came off Adderall. And when I did their follow-up, they told me that, right? I didn't tell them to do it. We didn't even talk about it. But they both had said, hey, I just felt so good. I felt like I had so much better clarity and calmness that I actually stopped taking Adderall, and it's working.
Interesting.
So NAD's popular for sure.
Do you think for perimenopausal and menopausal women, it's for the calmness? Like less of this and more of
I think it gets around. I think one of the root issues with hormone decline is inflammation.
Yeah. And
I think when you've got this, kind of foundational component, right? Hormones are foundational. Cellular health is foundational. When you've got these things that are now working against us, where there's a promotion of inflammation, that's a huge issue. Okay. If you look at, I'll tie this in. I just did a talk in Vegas on the musculoskeletal syndrome of menopause. And I spoke to orthopedic providers, right? And my joke when I got there was like, guys, we're getting ready to talk about vaginas and hot flashes. And one of the board members was like, he's like, I've been a part of this board for 20 years. I've never heard anybody say vaginal dryness from the stage. Yeah. I was like, I'm honored.
There's no cast for that.
But what's important in that field for them to know is that 84% of women in perimenopause and menopause experience musculoskeletal pain. And the reality is, even in my world, unless I'm specifically asking, which I am, but most of the patients don't associate, right? So they won't come in and say, "Oh my gosh, Josh, like my joints are hurting and I think it's menopause." Now they'll say hot flashes or brain fog, like they know to associate those symptoms, right? So the point in that conversation is, you guys in orthopedics may be the very first person that they're walking into who is not looking at this. And what was so fascinating to me, and I'm not surprised, was when I asked the question of how many people in the room actually refer out to, hormone specialists, endocrinologists, 3 people.
Well, yay for those 3.
I know. And so it was really fascinating, but you can just see like where this huge void of adequate healthcare, because what's going to happen is if you walk into an orthopedic office right now and you say, my hip is hurting, they're going to take x-rays, and majority of the time the x-ray is going to be normal. And they're going to say, it's probably just a little bit of synovitis, which is inflammation of the joint. And we're going to give you some meloxicam, which is an anti-inflammatory. We're going to put you on PT and we want you to rest. All 3 of those things are helpful. I'm not saying it's not, but at what point did they ever say, okay, you're a 50-year-old female and I don't need to know a ton about hormones, but perhaps there could be a component. And if you look at the where the connection is physiologically, when estradiol levels decrease, which is happening in your body, so when estradiol levels decrease, inflammatory mediators like interleukin-1, interleukin-6, tumor necrosis factor alpha, all of those increase. So you're losing your ability to fight inflammation. Does that make sense? So you've got this lack of natural protection around inflammation. So now all of a sudden my joints don't have those inflammatory mediators to combat some of the problems, and therefore joint pain goes through the roof. And so, I think it's a great opportunity for that group of people, because I worked in orthopedics for several years, And I joked, we had this rule in the practices that I would work in. If somebody came in and said, I've got shoulder pain, elbow pain, knee pain, our response was, you get to pick one.
You have to pick one that I'm going to play with?
Yeah, because I can't x-ray you. I'm not going to x-ray both shoulders. I'm not going to x-ray both elbows. I'm not going to x-ray both. Nobody does it. I'm just telling you, like, there's not an orthopedic surgeon. Maybe there's one or two, but most orthopedic surgeons will say.
What if I pick the wrong one?
That's my point. Right. So it's the inability. And then even further in that field, you've got the problem now where orthopedists have become so specialized. Right. I have orthopedic surgeons who only do hips and knees. Right. That's great because they're really good at that.
Right.
But again, it's having the understanding that, hey, when I'm coming in to see you and you're complaining of right hip pain because you got referred to me, should I be also asking, hey, are you having problems anywhere else? And is it unreasonable to at least consider a referral or just check some basic labs on them? So I just educated them on, here's what here's the process, here's what's happening in these women's bodies. Here's the labs, here's the basic concept of what menopause is and perimenopause. Here's the labs, here's what they're going to look like. And then you will look like a savior. And it was so funny, and it happens every time I do this specific talk because I'm talking to so many new people. I mean, I can't get out of the room
without them swarming.
Oh my gosh. It's like 50% of the women get them up there and they're like, thank you so much.
Oh my God, Josh Porter.
Well, or they're like, I want to know more about this, because they see it and they are hungry for getting that information to their patients, right? They want to care for their people. And so it's a really fun topic to discuss because, again, at the beginning of the conversation, I usually poll the audience. I'm like, all right, how many people in here are overly familiar with menopause? And nobody raises their hand.
Like,
so then I'm like, well, I can tell you all kinds of lies and you'll never know the difference, right? Like you can't question because I'm the smartest person in the room about this topic.
And I don't even go through it.
Yeah. So yeah, it was kind of funny, but it's a really common thing for women like you to be experiencing, and nobody really knows.
Would it be fair to say that the people that the orthopedic doctors are seeing are fairly active?
It's a across the board, but what would be fairly, because I did the research on this. So 50% on average, 50% of the patient population of an orthopedic office is somewhere, and it's men and women, 45 to 60.
The age is 45 to 60?
So male, female, they're average. So 50% of the people walking into an orthopedic office is going to be somewhere between 45 and 60. So half of that, right, would be the female population. So 25% of the people you're seeing on a daily basis will be females between 45 and 60.
Okay.
And so if 84% of those women have joint pain, perhaps you're missing something.
If we were, I'll just in like super, super layman's terms, what you're saying, and tell me if I'm wrong, if I'm picking this up incorrectly, but what you're saying is because their joints are hurting, lack of lubrication, for lack of a better explanation, which would potentially be coming from estrogen. Is that right? Is that like super, super, super layman? It's
more, let's say you've got a little bit of wear and tear. And historically, you have in what's called inflammatory mediators that are able to combat that, right? So your threshold for tolerance is high.
Okay.
When estradiol levels, so it's an indirect, but when estradiol levels are low, you lose your inflammatory mediators.
So it's what you can stand, not necessarily the lubrication portion.
Correct.
Okay.
So
I am wrong in what I was picking.
Well, you can almost compare it like if I had low white blood cells, I could not fight infection, right? If you look at a white blood cell, it goes up when you're having an infection because your body's trying to beat it. The same is true with inflammation, right? If I don't have enough inflammatory mediators, I don't have the capacity to fight those things. And therefore, inflammation starts running rampant. And inflammation is not isolated. It can be isolated into a joint, but it also is so systemic, right? So it turns out in gut health. It turns out in brain fog. It can turn out in dermatological issues, right? I mean, people can get breakouts in skin and all those things. So that's the component is it's really how estrogen ties into inflammatory responses.
Okay.
Systemically.
Okay, that makes more sense. Because I thought this entire time, I'm like, okay, so I'm literally like bone on bone rather than having a buffer in between.
Mm-hmm.
And it's not that. It's a matter of my brain's going, I can't handle this.
Yeah.
That makes a whole lot more sense.
So another
honestly.
thing, I'm glad you brought that up. There's another component, not just inflammation, but in your what's called neurotransmitters.
Mm-hmm.
So neurotransmitters like dopamine, serotonin, norepinephrine, and GABA. Mm-hmm. And most of these neurotransmitters, they have different functionings, feel good, calmness, things like that. But most of these also play a role in your threshold neurologically in how you tolerate pain. Mm-hmm. So as neurotransmitters are diminished, which is also a result of loss of estrogen, your capacity, right? So if your pain when you had hormones would have been a 5 out of 10, your pain without hormones may be a 7 out of 10.
Okay.
It's the same stimulus,
Same pain.
but it's a different ability to tolerate it because you've lost those neurotransmitters because you've lost your estrogen.
That's way different than what I thought, truly.
Yeah.
Because I thought, okay, how do you build back up the buffer between those things? And it's not about building the buffer. It's about your brain going, all right, girl, you got this. Well, as opposed to, okay, I'm just a big baby and it hurts a lot.
and I think this is a good point because the way I hear what you're saying is like, so let's say somebody does have a little bit of arthritic changes. Mm-hmm. They still may need something orthopedically.
Sure.
Right? It's not to say, but again, my argument would be, well, if you replace their estradiol, even if they need something orthopedically, I can just tell you right now, you have some kind of surgery on a joint, you're going to have inflammation. Your joints are going to swell from that. Mm-hmm. And so how am I even recovering from that? I mean, this should be in my opinion, this should be a conversation that is because it's going to equal better outcomes. Mm-hmm. And every orthopedic surgeon that I know is interested in better outcomes, right?
I'm certain.
So it's like, why wouldn't you want to know these conversations? It's just like vitamin D. Vitamin D is a very popular thing that a lot of orthopedic surgeons want to know about because it helps with healing. Mm-hmm. And so they check those levels. It's not uncommon. I just think that they should be incorporating HRT in a lot of how they look at initial patients as well as recovery from surgery and things like that, because it would broaden their understanding and their ability to help their patients.
Would you suggest if there is a male or female within the age bracket that you're saying is the most popular to go into an orthopedic surgeon's office, could they request, hey, do you think you should take a look, or can we take a look at before we do a surgery or we do something like that? Like, how do you have that conversation without, number one, feeling like you just went on, WebMD and diagnosed yourself? Or, you know what I'm saying? Or I don't want to say disrespectful, because being an advocate for yourself is not being disrespectful. But how do you have that conversation with a doctor to say, hey, can you make that suggestion? Can we do this? What does that look like?
I think in my opinion, which is why I take this message to providers, I think it's got to start with them knowing because they wouldn't know what to do with it.
Okay.
If you took that question to majority of orthopedic specialists, they won't know the first test to order.
Okay.
And then they won't know how to interpret
it.
That's fair. Because then they'll look at it and say, well, your levels say they're normal. And I actually show this because, I used a 54-year-old female's labs, and her FSH was 67. Mm-hmm. According to that reference range, that's normal because she's postmenopausal. But the reality is that's a signal that her estradiol levels are low, right? But if they don't know what they're looking for, it's not going to help them. Mm-hmm. And so I think I don't think it's unreasonable, but I think until we can help them from the provider standpoint, help them understand like what they should be looking for. Mm-hmm. You're probably, if you ask that question, you're probably either going to get dismissed or you're going to get referred, right? You're going to get kind of labeled and sent out to, and then herein lies is the issue, right? Mm-hmm. We're so focused on so many different things that it's like, who do you send that person to? Well, endocrinology doesn't really treat most postmenopause. Your gynecologist connecting it with joint pain is not going to be able to to connect those things, right? Yeah. So again, here's my pet peeve with women's health is that there's so much discrepancy and discrimination in it, in the sense of like there is no cohesive person or specialty out there really looking at it from the holistic standpoint. So
that's frustrating, Josh.
It is super frustrating.
That is frustrating because it's you want to advocate for yourself, and even if you are, they don't know what to do with it.
Mm-hmm.
What do you do?
Yeah.
Where do you go? What do you do? Help me.
Well, I think you find somebody who's at least willing to have a conversation. And so I think you pose your questions, you pose your frustration to anybody who's willing to listen.
Okay.
That goes a long way, in my opinion. So I'm not saying don't ask the orthopedist, and as long as they have a response of like, I hear you. I don't know what to do with that, but I hear you. I think most patients would be fairly well, respectful of that answer. Good.
I think that's part of one of the biggest things for women is how, what, where, who, so it gets very heavy at times, I think, because, I've told the story many times about when I came to you and I was like, I've been told literally the one phrase, and I think this is male or women or men or women. We just heard one of our men friends say that he received the same thing. It's your age.
Mm-hmm. No, we did. Yeah.
Those are fighting words.
Yeah.
Those are fighting words. Don't tell me that.
Right.
Do not. That's not a fix. That is what I like to say is a Band-Aid to a bigger problem. I'm just going to slap this Band-Aid on it, call it your age, and send you on your way.
And just get you out of the office.
Yeah. Deal with it.
Yeah.
And so that's very frustrating.
Yeah.
So I think that we are very lucky in the age that we're in, that there's so much information like on social media and on the internet and things like that. But at the same time, it's kind of crippling, because if you don't have a friend like I do in you, that I can go, oh my gosh, listen to this.
Right.
And what's this? And who's that? And those kinds of things. It can be very like, who's telling the truth about what here? Where do I go? What do I do? So I think, what if you were going to give a message to someone who doesn't have a you in their life, and I'm very thankful that I do, but that doesn't have a you in their life, what would your message be in terms of how do I find the person that's going to listen to me? What help can I look for?
No, it's a great question. It kind of ties into some of the vision that we have with this podcast, because with Optimized Health, we've created this podcast for 2.5 years now, and we really feel like there's more to add. And so, we're creating roadmaps for our patients to where they can really kind of help navigate these things. And really the goal is to just give those resources, right? Have these kind of discussions that mainstream medicine's not willing to have these kind of opportunities, have these, have people on the podcast our plan is to create courses and modules and, webinars and things like that, where we can have some conversations around these topics that will allow people to feel heard and to navigate it. Because we can't service everybody, right? We can't even service everybody in Chattanooga. And so how do we get that message to the masses? And I think the best way we can do it is to create a platform where those messages are easily accessible, and in a way that can help maybe navigate some of these issues. So I think hopefully in the next, 6 months, as we kind of develop this protocol and these plans and create a new platform for Optimized Health, I think that's going to be a great resource. I think there are other people out there doing it, from Peter Attia to, even some like Ben Greenfield. I mean, there's some really good people out there having hard conversations around some of these topics. But, there's great books. Estrogen Matters is a great resource. The Menopause Brain is a great resource for people who are trying to navigate like the brain clarity, brain fog issues. So and then social media is powerful. I mean, it just is. There's tons of people out there kind of screaming from the rooftop. The problem is how do you navigate and kind of work through like who's legit and who's not, and so that's always kind of a frustration. But I would just err on the side of more knowledge, even if it's the wrong knowledge or knowledge that isn't always cohesive, is better than no knowledge at all.
Yeah.
Right? Because if you're just saying, well, nobody's willing to help me, and I'm not gonna push for this more than my doctor's willing to do for me, then you're probably going to limit yourself. Because I tell patients all the time, medicine's shifting from the standpoint of as a provider, as a physician, when people of influence in the medical world tell you to do something, historically for years you just did it. Really, we did not ask questions because it was not easy to find, right? You don't have the written textbooks and your dictionaries and your your encyclopedias. I mean, it was just not easy to get that information. Now it's so easy that healthcare has to shift from a standpoint of what I say is the written law to the patient's who's taking ownership of their body is where it starts, right? That's the authority. And then healthcare is meant to be a support. And so finding that support system, I think is going to go a long way for somebody who's willing to put in that work.
Well, I thank you for that.
Yeah.
I mean, you truly are a pioneer in taking control of your health, and not just your patients, but now
me.
You.
Yeah, look at me.
So I know. Don't break your arm.
Yeah.
Patting yourself on the back.
That's right.
I mean, some of us can do it too for you.
What can I say?
But thank you for that.
Yeah.
I appreciate it.
Well, it was fun to walk in here and have an off-the-cuff conversation.
Literally off the cuff.
That we could. I mean, I've got so many different topics in my head. I'm like, we could go on debunking myths and all this stuff. But anyway, we're catching up on an hour here, so we better leave
wrap
pretty
it
quick.
up.
Mandy Livingston, thank you.
Oh, no problem.
And until next time.